So with a show, these are my disclosures, so I have a direct conflict here, so please keep that in mind as you listen to this talk. So with a show of hand, who uses technology when they do an anterior approach? So not even fluoro. What about fluoro? Okay, so most of you are using something. All right. So, fluoroscopy is easy. It's accessible everywhere, ASC, hospitals. You can use it for multiple procedures. Sometimes you can bill for it. So it's everywhere. So it just makes sense to use fluoroscopy, especially in an ASC. And, with fluoroscopy, we've shown that at least in the position of your cup, it's a pretty powerful tool. And back then when we published this, we were just eyeballing fluoroscopy. But when we looked at our numbers, we were doing pretty good. And now there's technology that kind of try to put a little bit more meat on the bone with this. You have OrthoGrid, and I apologize, this is a very old OrthoGrid slide. But now what's happening is there's technology to try to give you information about what you're looking at in fluoroscopy and not just eyeballing what you're looking in fluoroscopy. This is OrthoGrid. And then there's the Balance Hip Navigation, which can give you an idea of what your cup placement is in that specific pelvic tilt that you have. And then it also gives you with ipsilateral or contralateral overlay, it'll give you an idea of where you are in terms of leg length and offset from where you started to where you are with the trial implants there. And it's a small tower. It fits everywhere and just plugs into the fluoro machine, and then the fluoro machine just feeds the images into the tower, and then you can do the analysis. And this is run by your rep as you're doing the operation, so it's pretty efficient. Now, what do we do with these patients that have these spinal pelvic issues that we talked about yesterday? I mean, should we look into this before surgery? Do we care about it? Some people say we should not care. Joel doesn't care about it. So is there a role for something to look at this? And there is, because we know that people with spine issues dislocate at a higher rate no matter what approach you use. And this 18% of revisions in this country are done for instability. And this is JV's data from HSS, and he looked at 111 dislocating total hips. And what he found was that without the use of a hip spine imaging protocol, 77% of the acetabular components would have been recognized as correct when in fact they're inappropriate for that particular patient. So I think there's a role in looking at this, and I'm going to show you some examples. And the issue is, and I think Charlie alluded to this, should we screen everybody? Should we screen only patients that have hardware? Well, if you look at JV's data on total hips, 6% of them had stiff spines, and only 20% of them had a spine fusion. So if you're only looking at hardware to kind of see what patients are at risk, then you're going to miss the vast majority of these patients. So Cuptimize is a pre-analysis tool and an intraoperative execution tool. And it's pretty simple and fast. You take 4 x-rays preoperatively. You take an AP standing and supine AP pelvis. And what you do, and this is done by my rep, I don't do this, you draw the SFP angle. And then you take 2 laterals, a sitting and a standing, and all you do is you draw the end plate of S1, and automatically the system will draw the sacral slope. That's all you do. It literally takes less than 30 seconds to do, and it's done by the rep before surgery. And then it'll give you this information, and this is this specific patient, that if you put this cup at 40-20 in the supine pelvic tilt, this is where it's going to be standing and sitting. So you can see that this patient, when he sits, he actually rolls forward and loses an aversion of the cup. So then you're like, well, okay, if I look at this and I'm thinking maybe I'm going to put a dual mobility on this guy, and in the ASC it's a more costly implant and I don't have access to it in the ASC, well, maybe it'll change your decision making in terms of where to do a case like this, right? And then in surgery, it actually, an unintended consequence of this technology is that in surgery you just draw the SFP angle, right? You draw this so the system already knows what the pelvic tilt is there, and it already knows what is going to be sitting and standing. So when you put the cup in, it'll tell you, well, the cup is at 40-23 here, but it's going to be here standing and it's going to be here sitting. In this specific case, I kind of erred a little bit on the more anaversion side so I could stay within the confinements of the bony anatomy. So I recognize that and I use a dual mobility. So now you get an AP pelvis in the office. you go to you get the AP pelvis and the fluoro, and you don't have to be tilting your machine to get the right tilt that you're aiming for, because it's more like a visual, qualitative thing instead of a quantitative thing. So now you avoid that by just drawing the SFP angle, and you know where the pelvic tilt is there. And then to finish, yesterday I posed a question that I don't think a lot of people know, and I don't know the answer to this, and it's, should we be getting relaxed seated or forward flex seated x-rays? And I'm going to show you this case. This is the standing lateral. Look at the sacral slope. And this is the relaxed seated. Look at the sacral slope. It does what you expect it to do. It rolls back. So that's good. And if you run the analysis, this is a perfectly fine patient, low risk patient. You put the cup of 40/20 and you don't even have to think about it. But look at this now. If you get a forward flex seated x-ray on this guy, it rolls forward a lot. And if you run the analysis, if you put that cup of 40/20, you have no aneurysm when that patient is rolling forward in a seated position. I don't know the answer of where to go here, but I'm looking at that and I'm like, I'm going to throw in a dual mobility just in case, and I'm going to do it at 40/30 in the standing position. So again, it gives you information that we may want to know or we may not want to know. And so, I think Cuptimize and VHN in the ASC is, gives you valuable pre-op, intra-op information to help decision making. There's no advanced pre-op imaging required. There's no disposable pins and stuff like that, like in robotics, which can bring your cost of surgery down. It improves their workflow. And, if you're in high volume ASC, this is kind of like a yearly subscription that it's pretty cost effective. Thank you for your attention.